Okay, I have just a couple of brief announcements before we start the next lecture. We'll have a lecture here on secondary hypertension evaluation. Ballroom C, which is over that way, has a lecture on the pre-litigation committee and clinical excellence. There is a skill lab at this time, 3:30, for teamwork communication with Joshua Morris, who gave the lecture regarding the cave rescues. That is in room 320. There's also a skill lab beginning at this time for possible abortion care in room 312. Okay, our next speaker, I presume that is you. Our next speaker is Dr. Sarah Gilligan. She's also sponsored by our longtime partner, the Kidney Foundation of Utah and Idaho. We'd like to, we'd like to thank the National Kidney Institute. Okay, thank you. This is all printed out for me. I've read it before, but it doesn't necessarily mean I'm doing a great job with it. So let's welcome Dr. Sarah Gilligan. Advance your slides. Okay, green with an arrow will advance, red with an arrow will take it back.
All right. Hi, I'm Sarah Gilligan. I'm an assistant professor in adult nephrology at the University of Utah, and I'm going to talk to you this afternoon about evaluating secondary hypertension. And listening to Dr. Grenzel's lecture, it does seem like there's quite a bit of overlap, so hopefully it'll hammer everything home. So we're going to talk about patients who have risk factors for secondary hypertension, how to evaluate the different causes, how to manage the different types of secondary hypertension, and then also to recognize when specialist referral is needed for these patients. Why are we talking about this? So in the United States, almost half of adults have hypertension. About 10 to 20% of those have secondary hypertension. And it's important to recognize these patients because a lot of these secondary hypertension patients have a cure or a targeted treatment that will really help them. So all your patients with hypertension should have a thorough history, examination, medication review, and some initial labs, which we'll talk about. But it's not necessary or really cost-effective to perform a full secondary hypertension workup on all the patients that you see. So important to recognize who would benefit. So we'll kind of talk through a few cases as we go here. The first is a 28-year-old man. He's coming into clinic to establish care. He has no health issues, takes no medications, no complaints, feels well. He lives with his wife and daughter, works as a financial planner. He's never smoked, used drugs, and drinks a moderate amount of alcohol. He does have a history of hypertension in his father, but this was diagnosed much later, around the age of 55. Doesn't have any other family history of kidney disease or other pertinent issues. Coming into the clinic, the really notable thing with his vital signs is his blood pressure is 155/92, and you confirm this on serial readings. Otherwise, everything with his vital signs and his exam are fairly unremarkable. His BMI is just mildly above the normal range. So this, I think, is probably harder to see than I realized from down there, but I'll talk you through it. So kind of an evaluation of this patient, the first thing you want to think about is, okay, his blood pressure is high. How high is it? If his blood pressure is over 180, over 120, or he has hypertensive emergency with signs and symptoms of end organ damage, this patient has hypertension. If his blood pressure is not quite that high, then you kind of want to think down this pathway. So again, if he's over 160, over 100, and has signs and symptoms of end organ damage, then that's pathognomonic for hypertension. If his blood pressure is more in the mildly elevated range, then you want to think about some secondary evaluation. So you can either do this by home blood pressure monitoring to confirm whether his blood pressure is high at home, or you can do a 24-hour ambulatory blood pressure monitor to confirm his hypertension. And while you're doing all of this, you also want to do some initial laboratory evaluation, including checking his kidney function, urinalysis, and EKG and lipid panel. The reason that we're going through all of these steps is that we have to remember this graph. So we all know the patients with hypertension. We all know the patients with white coat hypertension, where they're high in the office and then normal at home. But I think this group is under-recognized, the masked hypertension. So these are the patients who are normal in the office, or maybe sometimes just a little high in the office, but then at home their blood pressure is actually worse than what we're seeing. So it is worth having your patients monitor their blood pressures at home. Back to our patient here. He comes in for a follow-up visit, and his blood pressure in the office is a little better. It's 133/83, but he's been pretty consistently monitoring at home, and you can see that his blood pressure is falling well above the 130/80 range on average. So this patient truly does have hypertension. What are we going to do next for this patient? Maybe more than one thing. So, of course, we're going to do lifestyle modification and guidance on a low-sodium diet, making sure he's exercising. But if this patient's already pretty healthy and doing these things, you may even jump to starting an antihypertensive. Because this patient is 28 years old, he's also somebody in whom we want to begin an evaluation for secondary hypertension. And again, because he's so young, he might be somebody that you refer to us in nephrology right off the bat rather than waiting. And as I mentioned, we'll do some initial laboratory evaluation to see if there's an obvious underlying cause or other abnormalities that need to be addressed urgently. So we get some initial laboratory evaluation on this patient, and generally things look pretty normal. His blood counts are fine, his urine doesn't show any protein or blood, his lipid panel is okay, his EKG is normal, and really the only thing on his metabolic profile you'll notice is that his potassium's low, which is odd for a young, healthy man. So this should be starting to kind of get your brain turning. What might be going on with this guy? Which brings us to discussion of which patients should be evaluated for secondary hypertension. So as Dr. Grinzel said, patients who are developing hypertension at a young age, you always want to think about, is there an underlying cause? Certainly before puberty, really before the age of 30, in the absence of any significant family history of hypertension, patients who are morbidly obese, who might just have essential hypertension even at that young age. Any hypertension that's associated with electrolyte or acid-base abnormalities should raise suspicion that there's something more going on. Patients who present with malignant hypertension, signs and symptoms of end organ damage without a prior diagnosis, that's concerning for a rapid escalation and a secondary cause. Patients who have an acute change in blood pressure or an increase in the lability of their blood pressure that's been stable and well controlled for many years, you should think about whether there's something else happening. Patients who have severe resistant hypertension, meaning that they're on 3 medications at good doses, including a diuretic, and their blood pressure is not controlled. And then those with signs or symptoms of diseases that are associated with secondary hypertension, which we'll talk about. These are our common causes. Primary hyperaldosteronism, we'll talk about this in a moment, but it's under-recognized. Chronic kidney disease, including our patients with polycystic kidney disease, in whom hypertension may be their first manifestation, even before they have abnormal renal function or any urologic abnormalities. Obstructive sleep apnea, very prevalent in our population. Renovascular disease, and then medications and substances. Hopefully this matches up with Dr. Grinzel's list pretty well, so we're not giving disparate information. But ones that people may not always think of are oral contraceptives, testosterone. For some reason, we've been seeing a huge increase in the number of patients in our clinic who are on testosterone, and it does have an effect on blood pressure and kidney function itself. NSAIDs, of course, certain types of chemotherapeutic agents, stimulants such as cocaine or methamphetamines, calcineurin inhibitors such as cyclosporin or tacrolimus, antidepressants of certain types, and then these ones at the bottom we'll talk about a little bit more later on, but they can actually cause or mimic hormonal types of hypertension. All right, laser switch. And then these are the more rare causes of secondary hypertension. We love looking for Pheochromocytoma because it's a cool diagnosis, very, very rare. Cushing syndrome or hypercortisolism, coarctation of the aorta, hyperthyroidism. I say not because it's rare, but because it's rare that hypertension would be the presenting symptom. Hyperparathyroidism when associated with hypercalcemia, and then these other rare disorders, which I think are very interesting because they really look at how things are handled in the kidney and what's going on to cause hypertension. So how do we begin the workup of these patients? Sleep study in anybody who has a high index of suspicion for obstructive sleep apnea. This bedtime salivary cortisol we'll talk about a little bit more, but this is to screen for Cushing syndrome. Screening for pheochromocytoma we do, although it's very rare. It's an easy screening test to complete. TSH, PTH if your patient has high calcium, and then 8 a.m. or early morning aldosterone to renin activity ratio. This is important. It's not valid if we test this at 4 p.m. It's not valid if we test this at night in the patient who's been laying in a hospital bed all day. This is where our really validated norms for these numbers come from. And then based on that, we can determine where to go with further testing if one or both of those values are abnormal. So back to our young gentleman, our 28-year-old with hypertension. We start him on some amlodipine, refer him to nephrology, but you, as primary care providers who have been through this lecture, decide to go ahead and start getting some workup so that nephrology is ready to go. And you get the labs as shown below. And what jumps out as abnormal here? Yeah, look at that aldosterone, and in particular, aldosterone to renin activity ratio. This is wildly abnormal. Everything else looks pretty good. So now we're thinking this patient has primary hyperaldosteronism. And as I mentioned earlier, this is more common than we previously thought, around 12% perhaps in primary care patients, and up to almost 30% in those who are referred for specialist care. This classic triad of hypertension, hypokalemia, and metabolic alkalosis is rare. Hypokalemia itself is only present in up to 37% of patients. So these patients can come in with hypokalemia and normotension. They can have normokalemia and hypertension. They can have easily provoked hypokalemia when you start them on a diuretic. So you do have to have a high index of suspicion. But this is back to that slide earlier at the beginning when I said any electrolyte abnormality plus hypertension should prompt additional evaluation. All right, so how do we diagnose hyperaldosteronism? So as I mentioned, we should consider this in patients who have hypertension and electrolyte abnormalities or these other types of secondary hypertension triggers. The case detection should be done with this first morning plasma aldosterone concentration and renin activity level. And then you can stratify patients. If they have a low aldosterone and a higher normal renin, probably not. If they have at least a moderately high aldosterone and a suppressed renin, then you want to think about, do they have hypokalemia and a very high renin? Okay, those patients probably have primary hyperaldosteronism, and we can move on to the next step. If somebody doesn't have the confirmatory characteristics, then some additional evaluation needs to be done. The one of these that I use most often is this 24-hour aldosterone because it's easiest to do. A lot of our labs are not familiar with the sodium saline suppression test. So what you do here is have patients eat a very high sodium diet. It's the only time that we tell our hypertensive patients to go ahead and take salt tablets. They have to be taking in at least 6 grams of sodium per day typically for 3 days. And then on the final day, you have them measure a 24-hour urine to measure the aldosterone as well as the sodium to confirm that they were on an appropriately high sodium diet. And just a reminder, because I'm a nephrologist, how all this is working. So aldosterone is binding to the mineralocorticoid receptor here and stimulating the ENaC channel in the collecting duct. So this would be a cell in the distal nephron. And that's from the urine side here, causing you to reabsorb more sodium, which is ultimately leading to more sodium being transported into the blood, drawing fluid with it, and leading to hypertension. So in patients who have sort of constitutive activation of this channel, either due to aldo that's not being shut off by hypertension, or due to some of these other syndromes that we'll talk about later, they're just going to keep reabsorbing sodium despite being hypertensive and just continue to make themselves more hypertensive. So one more note about evaluation for primary hyperaldosteronism. In our labs, we have two different choices of what to order. There's a plasma renin activity and a plasma renin concentration. In most situations, probably either are acceptable. However, in women who are on combined contraceptives or hormone replacement, it is preferred to use the renin activity because there may be some other substrates of renin that are not being measured but are active, so it can lead to a false positive screening in these patients. By convention, most of us at the University of Utah, I think, just use the plasma renin activity. It's sort of what we've grown up on. So that one won't steer you wrong in any situation that I'm aware of. And the other thing to think about with this is which medications can affect our testing. Really, the big ones are the mineralocorticoid receptor blockers, spironolactone, eplerenone, and then finerenone also, the new kid on the block. And opposite of what you might think, they can actually lead to false negative testing. You would kind of think, oh, I'm blocking aldosterone, the level's just going to go up. But if you're blocking aldosterone in somebody who's become accustomed to a very high level of aldosterone activity, it can actually induce enough hypovolemia to kick on the renin and lead to a false negative result. Other medications may have an effect on these levels, including ARBs, ACE inhibitors, as well as amiloride, but we do not routinely hold those medications prior to this testing. So back to our patient, kind of going down our pathway. He's a young man. He's under the age of 30. He has unequivocal primary hyperaldosteronism by laboratory criteria with a plasma aldosterone of 32 and a plasma aldosterone to renin activity level of 160. So our next step would be to do a CT scan of his adrenal glands to assess for an adenoma. And this can be done with or without contrast. Contrast is preferred. And basically, this is being done to subtype the patient further. Does he have a very large mass, in which we're concerned about cancer? Does he have bilateral adrenal hyperplasia? Or does he have a unilateral macroadenoma that we think we might be able to target and cure this man's hypertension? Further kind of down the pathway for patients who are under 35, who have unequivocal hyperaldosteronism and a unilateral mass, those are the patients who do very well with surgery. You take out the mass and their hypertension is cured, or perhaps they just need one medication. So those ones you're going to jump right to surgery. For patients over 35, just because there's such a high prevalence of adrenal incidentalomas, you want to be really sure before you start to go cutting out adrenal glands. So our next step in these patients is going to be something called adrenal vein sampling. This is done percutaneously through the femoral veins, and essentially what they do is thread catheters up on both sides and measure the aldosterone as well as the cortisol concentrations from each adrenal gland as well as from the IVC. At our institution, we do this with continuous concentropin infusion. This stimulates cortisol production so that you know that you're in the right place. You should have roughly equivalent levels of cortisol coming from each adrenal gland because that access shouldn't be disrupted. And then you can use this corrected aldosterone ratio from the high to low side. If that's over 4:1, then that does indicate unilateral aldosterone production. So in this example here, you can see that the left adrenal vein had an aldosterone to cortisol ratio of 7.2, which is markedly higher than on the right. So this patient has pretty unequivocal left primary hyperaldosteronism. And then what do we do for these patients? As I mentioned, for young patients who are otherwise pretty healthy, adrenalectomy can often cure their disease. We can alternatively do medical management with mineralocorticoid receptor blockers as the mainstay of treatment. And with this, don't be afraid to really bump up the dose on these medications if your patients aren't well controlled. If we know this is the problem and we're targeting blocking this specific hormone, give them the spironolactone. Alternatively, you can use potassium-sparing diuretics like amiloride, though those aren't quite as effective. Most patients, though, will need this plus other antihypertensive medications. Any questions about hyperaldosteronism before we move on from this? Yeah?
Male patients that are worried about diagnostic and stuff, we give spironolactone. I've used Pheochromocytoma before, I just don't feel like it's as effective.
So the question is for male patients who are worried about or perhaps have developed gynecomastia with spironolactone. Eplerenone would be the next step. We don't jump to that right away just because of cost. And again, it might just be a dosing issue. You may have to up the dose. Other questions? Okay. Moving on to our next patient. This is a 65-year-old woman. She's coming in for an annual follow-up visit. She's got underlying hypertension, hyperlipidemia, and is on amlodipine and atorvastatin, and they've both been very well controlled. But today, she says for the last 3 months, her blood pressures have really been running high. She's averaging around 160/90, previously was in target range. She's not started any new medications, nothing else has really changed. She really only takes vitamin D as far as supplements goes. And kind of looking back over her history, you notice that she does have a significant smoking history, a 25-pack year history, but did quit many years ago when she was diagnosed with hypertension. So again, this should be kind of getting your wheels turning. Looking at this patient, she is hypertensive, 161/92, again confirmed with serial blood pressure monitoring. Everything else, again, with this patient looks pretty normal. The remainder of her vital signs, her exam. So you start with obtaining routine blood and urine tests. Looking at these, a couple of things to notice. She has a little bit of albuminuria, not terribly unexpected in a patient with uncontrolled hypertension. And similar to our first patient, she's pretty hypokalemic, with everything else appearing pretty normal. So what are we going to do next for this lady? Well, her blood pressure is pretty high, so we're going to want to add another blood pressure agent. Also, this is one of those situations I mentioned where all of a sudden, after a period of good control, she's developed labile blood pressures, increased hypertension. So we do want to look at a workup. And then we're going to want to follow her pretty closely as we're doing all of this. So you start her on the lisinopril. She comes back into the clinic in 2 weeks. Her blood pressure looks great, 120/76, but you get her labs, and things aren't going so well there. Although her potassium is normalized, her creatinine has over doubled in the past couple of weeks. So wheels should be turning. We have a patient with hypertension. We start her on an ACE inhibitor. She develops a significant acute kidney injury. So what are we going to do now? Probably stop her lisinopril, although it hurts my heart a little bit to say that as a nephrologist. We're going to watch her labs very closely. And we're going to look for renovascular hypertension. and probably send her on over to us in nephrology. Renovascular hypertension. This is hypertension resulting from a hormonal response to decreased renal blood flow by triggering the renin-aldosterone-angiotensin system. And this can happen from a variety of different causes: plain old renal artery stenosis, atherosclerotic disease, fibromuscular dysplasia, something you need to consider in younger patients who have evidence of renal artery stenosis, the arteridities, as Dr. Grenzel mentioned in his lecture, though rarely would this be the presenting symptom. Extrinsic compression. I have patients who have various types of cancers where it's compressing their renal artery and leading to this physiology. Dissection or infarction of the renal artery. Fibrosis, again, leading to extrinsic compression. And then obstruction from aortic graft, which is an interesting one that we see in the ICU up at the University of Utah at times. So these patients come in, they have an aortic dissection, they get fixed with the graft, but then it's sitting over their renal artery. And which patients should we be thinking about looking for this in? Certainly anybody who has a creatinine elevation when you start them on an ACE or ARB of over 50%. Moderate to severe hypertension in a patient who is a vasculopath, who has other evidence of atherosclerosis or a small kidney that isn't explained by other reasons, which can indicate a long-term reduced blood flow to that kidney. Patients who have hypertension and recurrent flash pulmonary edema, this is a consideration. Patients who come in out of nowhere with blood pressure of 160 over 100 or above. And then patients who actually have evidence of a bruit on exam, though hearing this, especially in adult patients, is very rare. So what do? Practically in clinic, the first thing that we often do is get a duplex. This is pretty good for just general atherosclerotic disease. You can also consider getting a CTA or an MRA. This would be more helpful in patients in whom you're considering fibromuscular dysplasia because that's often not evident on a duplex. And some patients actually need arteriography to diagnose this. You can get your renin activity or aldosterone to renin ratio as you would for these patients with primary hyperaldo and may have already done in the course of your evaluation for secondary hypertension. And these others, captopril renogram, I don't think is really done in practice. And in just one patient did we ever think about getting a renal vein renin measurement, which would be similar to that adrenal vein sampling that I showed you earlier. So what are we going to do? Contrary to popular belief, we're typically going to put them on an ACE or ARB. You want to start slow and watch them very closely, but often you can find a balance between what's going to kick them over the edge into acute kidney injury versus what's going to control their blood pressure. This really is what's getting at the underlying physiology of increased renin excretion. And then in some patients, you're going to think about revascularization. So the patients in whom you want to think about this are patients with FMD, young patients who've had a relatively short duration of hypertension and don't want to be on a blood pressure medication for the rest of their life, patients who are failing or not tolerating medical therapy, or who are having this recurrent flash pulmonary edema, which is a much more dangerous complication. And then for patients who have bilateral renal artery stenosis and or a single functioning kidney, you might also just do that if their kidney function is getting worse for no other reason, because it may be that if they're relying on this blood flow and it's not coming, that's going to be the only way to preserve their renal function. But I say all this, most patients, you're going to do medical management. This is not the thing that we need to jump to. Okay. Questions about renal artery stenosis? Slightly less encouraging story, obstructive sleep apnea. So this is a classic case of correlation is not causation, but up to 50% of patients with OSA have hypertension, and OSA is detected in up to 85% of patients who have resistant hypertension. So many patients with OSA have hypertension, many patients with hypertension have OSA. This is something we want to have a high index of suspicion for in patients who have obesity, snoring, daytime sleepiness, or other symptoms. But unfortunately, CPAP doesn't have a lot of effect on blood pressure in these patients. Although OSA is certainly contributing to their hypertension, probably via hormone dysregulation and other factors, treating their OSA doesn't by itself lower blood pressure. Though I will say anecdotally, it makes their blood pressure easier to control with medications. And then the most interesting part, kidney disease. So again, like with OSA, hypertension can occur because of kidney disease. So the kidney disease coming first, leading to hypertension. But hypertension is also the second most common cause of end-stage renal disease in our country. So either can come first. Most patients, up to 85% who have chronic kidney disease, also have hypertension. And the worse your GFR is, the more likely you are to have hypertension. It's very rare just before dialysis, I would say, for a patient not to require some kind of antihypertensive therapy. So this is kind of addressed in what we talked about earlier with our initial workup for hypertension. We're always going to want to look at creatinine, urinalysis, urine protein. And then for patients with family history of kidney disease, particularly polycystic kidney disease, which is fairly common in Utah, we may also just want to get imaging if we have a young patient with hypertension and no other cause, because this can predate any change in their creatinine itself. And so this is just a picture of somebody with pretty large polycystic kidneys here. For our patients with kidney disease and hypertension, our goal blood pressure is less than 130/80 or less than 120/80 by standard office measurement. This is rarely done properly, I would say, so there may be risk to patients if you're targeting a blood pressure of less than 120/80 and not measuring it according to these guidelines. Of course, with all patients, we're going to want to counsel regarding exercise, dietary sodium restriction. And then for patients who have proteinuric kidney disease, an ACE inhibitor or angiotensin receptor blocker would be our treatment of choice. Otherwise, you can take your pick. You can start with an ACE or ARB, you can start with a thiazide, or a dihydropyridine calcium channel blocker. I'm a fan of amlodipine also. All right. Now another rare cause, Cushing syndrome. So Cushing syndrome is really a blanket term for hypercortisolemia, and this can occur as a result of excess ACTH production by the pituitary gland itself, as in a pituitary adenoma. It can occur because of ectopic ACTH production. Lung cancers would be a big one that we would think of causing this. Or it can occur because of adrenal gland disease, being adrenal adenoma or bilateral adrenal hyperplasia. This does have some associated symptoms, including proximal muscle weakness, facial plethora, striae on the abdomen, easy bruising, supraclavicular fat pads, or kind of the buffalo hump, and then redistribution of body fat. So this should look like a patient who's been on long-term high-dose prednisone, though doesn't always. In Cushing syndrome, hypertension is occurring as a result of activation of that mineralocorticoid receptor that I showed you earlier by cortisol. In the normal situation, cortisol should be converted to cortisone, which doesn't act on this receptor. But if you're getting such excess production of cortisol, it's overwhelming your body's ability for conversion, and so there is some cross-reactivity with that receptor. And because of that, this can look a lot like hyperaldosteronism. So the patients can have hypertension, hypokalemia, metabolic alkalosis, but then if you test their aldosterone and renin, those levels should be suppressed. So that's how you're going to distinguish between the two. Now this is also important. We cannot diagnose Cushing's based on a random cortisol, a random ACTH, an 8 a.m. cortisol. None of those things are valid diagnostic tests. So we either need to do this with a 24-hour urinary cortisol. We have to be careful of that in our patients who have chronic kidney disease, a bedtime salivary cortisol, or a dexamethasone suppression test, where you give them 1 or 2 milligrams of dexamethasone and then test their cortisol afterward, which should be then suppressed. And then after this initial diagnosis, you then need to determine, okay, cortisol is high. Is this an ACTH dependent or independent process, so that you know where to go? In terms of management of Cushing's, so Cushing's disease is the subset of patients in whom the excess cortisol production is caused by pituitary production, so usually an adenoma. So you can resect that when possible. There are some options for medical therapy, or you can do chemotherapy or radiation. In ectopic ACTH production, as with the lung cancer, of course you would want to treat the underlying cancer if at all possible. You could consider adrenalectomy or medical therapy. Or in primary adrenal disease, if it's an adenoma, then potentially adrenalectomy or medical management. Bilateral adrenalectomy is a tough surgery, and patients do not feel well afterward because, as you can imagine, it causes a lot of other hormonal abnormalities, not just removing the cortisol. Okay. Any questions about Cushing's? Okay. Pheochromocytoma, we all love to talk about, rarely ever see. So this is a catecholamine-secreting tumor. It's officially called a pheochromocytoma if it is arising from the adrenal glands themselves. There's also a related tumor called a paraganglioma that can occur from anywhere within the sympathetic ganglia. So functionally, they would cause the same thing, but the nomenclature is different depending on where it is. It's a very rare cause of secondary hypertension, less than 0.2% of patients. And again, it has this classic triad, but rarely presents in that fashion. So this would be episodic headaches, tachycardia, and sweating. It can cause paroxysmal hypertension. Patients can go very high and then have wide swings in their blood pressures, and can cause kind of provoked paroxysmal hypertension with medications, activities, or position changes. Sometimes can be associated with syndromes such as the multiple endocrine neoplasia syndrome, neurofibromatosis, or von Hippel-Lindau, but it can also just occur independently. So initial testing for this should be a 24-hour urinary metanephrine. Plasma metanephrines we use more often just because it's easier to do, but there's a very high incidence of false positives with this test because it's officially supposed to be drawn from a patient who is supine from an indwelling catheter. If it's not done in this fashion, which it almost never is, you can get a false high result. If you confirm that you have high levels of metanephrines, then you're going to want to go to your imaging studies, being MRI or CT. And then there are also some other options if you don't find anything on these studies, including various types of PET scans. You do not want to do adrenal vein sampling on these patients, and you do not want to biopsy this. That can cause an incredible release of adrenaline in the body and have devastating consequences. So how are we going to manage this? Starting preoperative alpha blockade. You do not want to do unopposed beta blockade in these patients. You're actually preoperatively going to put them on a high sodium diet because it's very likely their body has become dependent on this high level of adrenaline. And when you remove that, they may have a crash in blood pressure. And then once you've initiated the alpha blockade for at least 7 to 10 days, then you can start with the beta blockade and then move to adrenalectomy or tumor removal. Okay. So these are the cool ones. Again, very rare, more kind of a question on nephrology boards than much of what we see in patients. But Little syndrome is constitutive activation of that ENaC channel in the distal nephron. So your aldosterone can be suppressed, but your ENaC channel is just decided, I'm open, I'm reabsorbing sodium, and it's going to lead to sodium and water retention, increase in blood pressure. So this is hypertension associated with hypokalemia in a young patient with suppressed renin and aldo, and it's treated with amiloride to directly block that ENaC channel. The next one here is Geller's syndrome. We did have a case of this at the U a few years ago. So the way it presents often is that you'll have a woman who's normal, And then during pregnancy, she becomes hypertensive and hypokalemic. And what's happening here is that there's a mutation of the mineralocorticoid receptor in which progesterone actually stimulates it to then stimulate ENaC and lead to sodium and water reabsorption. So this is actually also treated with amiloride. Spironolactone paradoxically can cause worsening. Next is Gordon syndrome. This is one that's sort of different because this would be a young patient with hypertension, hyperkalemia, and metabolic acidosis. And this has to do with the thiazide channels. SAME, or syndrome of apparent mineralocorticoid excess, is a defect in 11-beta-hydroxysteroid dehydrogenase 2. So this is what's converting cortisol to cortisone. As I mentioned earlier, if you have too much cortisol, that's going to stimulate your mineralocorticoid receptor and lead to hypertension, hypokalemia, and this sort of pseudo-primary hyperaldo triad. And then this last one here, glucocorticoid-remediable hyperaldosteronism. Again, very rare, but very cool. So in this situation, somewhere in the gene processing, the promoter gene for ACTH gets flipped with the promoter gene for aldosterone. So in these patients, their body is sensing that they don't have enough steroid hormone, so it's telling the gene to make more and more and more, but the gene that it's actually working on is the aldosterone gene. So the steroid hormone gene is telling your body to make more and more aldosterone, and it's never going to catch up because it's still going to sense a deficiency of cortisol. So in these patients, they look indistinguishable from somebody with just general primary hyperaldo. But if you can diagnose this with genetic testing, you put them on a little dose of steroid, and it can resolve their hypertension, because then your body is sensing that there's some steroid there, so it can shut down that gene production. All right. So which patients here in these groups should see a nephrologist? So we're happy to see anybody with resistant hypertension, if you're having trouble managing a patient, if you're just not sure what to do. Anybody with suspected or proven secondary hypertension, maybe not those that are due to obstructive sleep apnea, because there's really not much more we can add in those cases, but we get really excited to work up primary hyperaldosteronism and renal artery stenosis and things in those of that nature. Anybody with hypertension and electrolyte abnormalities. And then hypertension with an underlying disease, acute or chronic. So in particular, as I mentioned, patients with underlying kidney disease, patients with polycystic kidney disease, as we can potentially intervene on these patients before they actually develop an impairment in kidney function. So how do I approach these patients who have suspected secondary hypertension? Again, first step, perform a thorough history and physical exam with particular attention to medications and supplements, as well as their physical exam findings. You want to do the initial workup with a CBC, renal function panel, UA, UPCR. I guess I left lipid panel off of this one, plus EKG at least once in probably all your patients who have hypertension. And then if your patients have clear signs and symptoms of secondary hypertension or you have suspicion, then you want to work that up. You want to refer patients with suspected sleep apnea for testing. And then in particular, for these patients with electrolyte abnormalities, if they have hypokalemia, then you want to look at primary hyperaldosteronism. So you can perform this 8 a.m. aldosterone to renin activity level. If that looks like primary hyperaldo, follow the algorithm. If your aldo's low and your renin's low and you really have strong suspicion, then you can kind of go down the rest of the pathway and look for Cushing's, Pheochromocytoma, hyperthyroidism, other things. If you have high aldosterone and high renin, then you're going to be looking for things in the family of renovascular hypertension. And then you always want to consider genetic testing for young patients who have hypertension, electrolyte abnormalities, and no other clear cause identified, because that could have implications for their treatment as well as for potential of reproduction in the future. So we have one more case here. So this is an 18-year-old man. He's coming in for evaluation of hypertension. He had a blood pressure that was 149 over 84 at evaluation with his primary care provider recently. He feels fine, takes no medications or supplements, doesn't really exercise, doesn't smoke, drink, or do drugs. He has been monitoring his blood pressure at home since that visit, and the readings are 130s to 140s over 80s to 90s. So he has hypertension. So bringing him into the office, his blood pressure is 147 over 88. The rest of his vital signs are pretty unremarkable. His BMI is 22.5. He's not overweight. So this is your prime patient. You're really going to go digging here for secondary hypertension. It's an 18-year-old. You want to fix this. So you get his initial evaluation. His labs are fine. No electrolyte abnormalities, no urinary abnormalities, no protein in his urine. And you go down the workup for additional causes of secondary hypertension. Really nothing lights up here. Everything looks pretty normal. You get a kidney ultrasound. His kidneys are normal size. There are no cysts. You do genetic testing. It's negative. So sometimes it's just hypertension. And I say this because especially earlier on in my career, when I saw these younger patients, I would get pretty excited and get them pretty excited that we were going to find something we could fix. But it is important to kind of temper expectations and let people know that you're going to be proactive and look at everything you can, but they may potentially just have high blood pressure. So that's about it. Are there any questions? Oh, is that not working?
So I kind of moved away from using ACE inhibitors quite a bit because I got tired of side effects and moved more towards angiotensin receptor blockers. Is that something that I'm doing wrong, or can you convince me to go back to ACE inhibitors?
The question is whether there would be a strong preference for ACE inhibitors versus angiotensin receptor blockers. No, either is fine. They should be relatively interchangeable. Any other questions? Yeah, that's a great question. So the question is, what's the difference between a urine protein to creatinine ratio and a urine microalbumin? So albumin is the most common type of protein both in our blood and our urine. So that's what you all use for screening in patients with diabetes. The urine protein to creatinine ratio measures all of the different types of protein in the urine. So we use that much more in nephrology. In particular, if it can tell us if a patient has any concern for a paraprotein disease, a myeloma, or amyloidosis, or things like that. So that's kind of what I put as my workup rather than albumin. And your albumin should be approximately 60% of your total protein. Other questions? All right. Well, thank you all.
Thank you.